Now, C516, cervical spine, anatomy and pathology. First we'll start with the bones. Here we have C2 through T1 vertebrae. We see that they all have spinous processes. They are occasionally bifurcated, most commonly at C5. Easiest to palpate, the vertebral prominence of C7. Second easiest, T1. The next easiest is typically C2. C1, not shown, does not have a spinous process. The discs are missing in the interbody joint here, but we can see the facet joint, or the zygapophyseal, or the Z joint. We see the lateral recess where the intervertebral foramen occurs, and in this foramen exits the nerve root and enters the radicular arteries, and that nerve root comes out what we often refer to as the gutters for the nerve root. When we talk about the articular pillar, this is what we're referring to, this column of blocks seemingly blocks posteriorly, and if we look at it from the front, and we can see the empty interbody joint where the disc goes, but along the side here, these prominences, the uncinate prominences that form the U joints, or the uncinate joints, between the vertebral body and the uncinate process, or oncovertebral joints. Here we see C1, which, as we mentioned, is missing a spinous process, although its transverse processes are actually quite wide and live just under the mastoid process near the external opening for the ear. We see the transverse foramen present in all the cervical vertebrae, and this is a superior view. This is the articulating process for the occiput, and this vertebra, also known as the atlas, since it holds the head on its shoulders. And if we look inferiorly, this is the facet for the C2 vertebra, or the axis. Here we see the dens, which is embryologically part of C1, although it is attached to C2. We see the atlas on the axis, and this is the AA lateral joint, and there is an AA medial joint, which is the articulation of the dens with the ring of the atlas. This is a sagittal section taken just off midline that goes through part of the occiput and the atlas and the axis. We see convex superior occiput, concave atlas, and with the living cartilage in place, as we see here, we see that both the axis and the atlas form convex surfaces, male-on-male joint surfaces, which is quite unusual arrangement. If we look into fractures, particularly in the upper cervical region, this is another photo, a midline sagittal section straight through the dens and the arch of the atlas. This is an obvious fracture. In the case of less obvious fractures, ones that are not displaced, they will tend to occur right about here, which is somewhat unfortunate, because in an open mouth x-ray, the x-ray we use to detect these fractures, this arch of the atlas casts a shadow right about where that fracture often occurs. So we can get some false negatives in our open mouth x-rays. Here is a Jefferson fracture of C1. This is usually a forceful compression of the head down on the spine or the spine up under the head. This is our dens and multiple displaced fractures. This is a teardrop fracture, which in and of itself, because it's anterior, does not tend to threaten the nerve roots or the vascular supply for the cord, but it is indicative of a severe hyperextension, avulsion fracture, or a hyperflexion compression fracture that likely did other damage in other areas of the spine. Here we have a hangman's fracture of C2 through the pedicle with displacement, and here we have either a degenerative or traumatic image of MRI image of a spinal cord injury. Because of that male-on-male arrangement of the AA joint, this joint is, in the absence of osteoligamentous stability, prone to dislocation. These dislocations have been classified by Fielding's work, and for our purposes aren't essential to know. In ruling out fractures, the Canadian C-spine rule has been developed. It goes through a series of questions. These questions are grouped in 3 clusters, the first of which, if the patient is elderly, has had a dangerous mechanism of injury, as defined by a fall from a height of greater than 3 feet or 5 stairs, an axial load to the head, a high velocity motor vehicle accident, an all-terrain vehicle accident, or a bicycle crash, then they get x-rays. If they have paresthesias in their extremities, they get x-rays. If none of these things are true, they pass to the second group of questions. Was it a simple motor vehicle accident? Can they assume a sitting position in the emergency room department? And have they walked at any time since the trauma? Any neck pain that they have should be delayed, not immediate upon trauma, and there should be an absence of midline tenderness. If all these are true, then cervical motion is tested. If they're able to rotate the neck 50% of normal, or 45 degrees, to both directions, no x-rays are needed. There is an alternate rule known as the Nexus Low-Risk Criteria, National Emergency X-ray Radiographic Utilization Study. This has been compared with the C-spine, Canadian C-spine rule. In utilizing the Canadian rule, sensitivity and specificity were enhanced and rates of radiography were lower. Now let's talk about the joints in more detail. Starting with the inner body joint and the disc. The cervical disc has always been assumed to be a smaller version of the lumbar disc. But with the relatively recent publication of Susan Mercer and Nikolai Bogdak's work in the late 90s, we found that it is much different than the lumbar disc. It contains a lot more collagen and a lot less nucleus. And the annulus is in a crescent shape, not the ring shape of the lumbar. The nuclear material changes with age, disappearing normally by the 4th decade, being replaced by fibrocartilage and fat. Here's a slide from their study. We can see the annulus in this crescent shape. Then it goes discontinuous, and then there's a small bit of annulus here. This 40-year-old person is filled with fibrofatty material instead of typical nuclear material as we might expect in the lumbar disc. If we look at these schematics, we can see it looks like a disc from the front, but when we look at it from the side, almost all of the body of the annulus is very far anterior. Because of that, the axis of motion comes around the anterior portion of the annulus. And as a result of rotatory movement, we see tears in the nucleus of the disc that begin to form shortly after the U-joints develop. Remember, these tears in the disc are part of normal aging. As these U-joints form, it changes the available axis, and we get this tearing occurring in the posterior part of the disc, which is completely normal and very different from what happens in the lumbar disc. In severe disc degeneration, I would call this disc obliteration, we see that this vertebral body has excessive ossification near the joint, as we see in all kinds of DJD, and we even see these little cysts developing. Usually we have excessive ossification, and then we go back a little ways and we start having relative osteopenia, and these cysts start developing. Another disc injury which has been identified in severe trauma is a disc avulsion or rim lesion. Here, where the disc has been ripped off the body of the vertebra. This typically occurs in the anterior aspect of the disc as a result of trauma into a position of extension. With provocative discography done in the 50s by Cloward, we see that the discs refer in these approximate areas. If we looked at the discs in relation to the exiting nerve roots, we see that our nerve roots exit right at the level of the disc, and they exit in a horizontal fashion. Thereby, the disc can only tag one cervical root. A disc herniation is made that much more unlikely due to the uncinate processes, which tend to somewhat protect the exiting nerve root. But discs do herniate. This material, this fibrofatty material of the nucleus, has extruded in this case from a mid-cervical disc and is affecting the cord. Cervical radiculopathy, which in more common terminology would be cervical radicular pain, is primarily a clinical diagnosis and is difficult to ascertain with imaging. Disc herniation as well as stenosis can be a potential cause for cervical radiculopathy. Here we see central stenosis, where either congenital or congenital and degenerative changes have narrowed the space for the spinal cord. This kind of stenosis is not amenable to our treatments. However, lateral stenosis can be. At this level, we see a nice patent opening in the intervertebral foramen in the posterior lateral view of the X-ray. But at this level, we see that disc degeneration, along with spurring, has reduced that lateral foraminal opening, which is where the nerve root exits and where the radicular arteries enter. In cervical radiculopathy, or cervical radicular pain, a clinical prediction rule has been found for this diagnosis based upon ipsilateral loss of rotation, positive upper limb tension testing, positive traction, and positive compression in Sperling's A test. In the normal intervertebral foramen with a full height disc, there is plenty of space. However, when we narrow the disc space, we often find that the opening gets significantly smaller. The facet joint, zygapophyseal, Z joint, is about the size of a pea. It's oval shape, and the inferior articulating process is slightly concave, as seen here. The joint is found halfway between the frontal and transverse planes. However, it's good to remember, as Kapanji shows here, that through the normal cervical posture, we see that the angle of those facet joints changes through the neck. So when we're mobilizing the joint, we'll have to account for this and change the angle at which we approach the joint. In the normal posture and upright, if we attempt to translate C2 anteriorly, there is a compression of this facet joint which will restrict that because of this angle, which is closer to 45 degrees. However, if we go down near the CT junction, we can see that this angle is far less, and particularly in the case of forward head posture, which would essentially rotate this entire diagram, these become horizontal, or in some cases even downwardly sloping, making this anterolisthesis much more possible at these levels where we see degeneration much more commonly over time. The facet joint, again, a slide from Rauschning, cut through the facet joint, shows that joint with these little meniscoids. These meniscoids, along with articular fat pads and capsular rims, have been implicated as a cause for an acute wry neck, that I slept in the wrong position or moved my head too quickly and now I can't move it, is proposed to occur when the joint opens. There's a displacement of this tissue that does not go back where it belongs. This tissue has been examined and has been found to have substance P. However, there are no diagnostic tests which demonstrate this interarticular inclusion objectively with radiologic testing. It is still a useful clinical model. Facet joint pain referral pattern has been studied with injection of hypertonic saline into the joint and produces these patterns of referral. Most commonly, this has been replicated later by Bogduck and is actually quite similar to the work shown with the cervical disc provocative discography by Cloward in the 50s. The reason for this is both the disc and the facet joint at any particular level come from the exact same embryologic level and therefore refer pain within a very similar or identical distribution. There is no way clinically, based upon a pain referral pattern, that we can identify the difference between disc referral and facet referral of pain. Something we need to remind ourselves and our patients is that there are asymptomatic findings on radiographs. Most patients expect to have diagnostic testing performed and often come in with an idea that degenerative changes shown in their X-ray, CT scan, or MRI show the reason for their pain. A study done in the mid-80s by Gore took 200 age-distributed, gender-distributed volunteers, each with no history of pain, no history of upper extremity symptoms, and performed lateral X-rays. About 10% of them had significant loss of lordosis, a pathologic finding in most X-ray reports, along with disc narrowing and associated posterior osteophytic changes. This was interesting enough, but even better, Gore did a follow-up study, published in 2001, with this same group tracked over 10 years. And with only one exception, the presence of degenerative changes in the neck did not correlate with the development of pain in the neck or the upper extremity over the next 10 years. The only exception to this was at the level of C6-7. If there were degenerative joint changes at this particular level, that individual was 4 times as likely to develop pain within the next 10 years. Now for the uncinate joints, or the oncovertebral joints, which are synovial joints. These processes form in our second decade of life, along with those posterior tears in the disc. What would be the reason for these joints? As shown here, when we side bend the neck, the vertebral body will tend to translate the opposite direction. It has been proposed that if the vertebral body side bent and translated to the same side, which would be potentially quite stressful on a structure which runs right through here. Now, when the vertebral body side bends and the distance between our transverse processes increases, the superior vertebral body translates closer, relieving some of that stress on, you guessed it, the vertebral artery. More pretty pictures from Rauschning showing the obliteration of the disc and severe arthrosis, structural changes in a joint, arthrosis, arthritis, inflammation of a joint. We can have arthrosis without arthritis. Arthrosis is what you see on an X-ray.